Good afternoon. Can I welcome you to the Ipswich Corn Exchange, to what we believe is a very important meeting for both hospitals and organisations in their history. It's a significant meeting for both boards, and members of both boards are behind me. If I can introduce myself, although I'm known to some, I'm David White, the chair of the Ipswich Trust and the Colchester Trust. And since May 2016, along with Nick Hume, who's known to many as Joint Chief Executive, we've been working with our boards to look at how we could strengthen the partnership between Ipswich, which serves East Suffolk, the Trust, and Colchester, which serves Colchester and North Essex. I'll explain how I'm going to run the meeting, but before I do so, it may just help, although many of you are familiar with how the NHS works, for me just to explain how boards work. We've two trusts, and we commission our services. We provide services through being commissioned by local CCGs, one in Suffolk and one in northeast Essex. Ipswich provides a range of acute and community services, and the Colchester Trust provides mainly acute services. Our governance is slightly different. In Colchester, there is a board of governors that are drawn from the local population and partner organisations, and that council of governors oversees the work and makes the appointments of the board, essentially the non-executives. And then we have a board, and they're behind me. They're a mixture of lay people who are non-executives and professionals in the executive role, covering a range of professions, including, of course, medicine and nursing. The Ipswich board is similar, except for the fact it doesn't have this overseeing council of governors. Both boards, at the moment, although they're working in partnership, are separate statutory bodies accountable to the Care Quality Commission, one of our regulators. So as I progress through the afternoon, both boards at the end of the afternoon will consider the full business case of why we should merge together and formalise this partnership. They will consider those in their own right. Although this is a meeting of the boards in public, we felt it was very important that we set out our stall again. We set out our case, which has been developing, as I say, over the last 20 or so months. So the introduction, after my introduction, Nick is going to go through a presentation and highlight the key aspects of our proposal. I'm then going to open that up to public questions, so any of you can ask any question. I will field those questions and determine whether Nick or members of the executive teams are best placed to answer those questions. Those who feel unable or don't want to sort of show their hand, we have got post-its at the side, so if you want to get up and scribble something, we'll make sure those questions are raised through me. And it would be very helpful, if you wouldn't mind, if you do have a question, if you were able to say who you are, because this event is being filmed and therefore will be going out live stream on YouTube. So it's an important part of the process that if you raise a question, if you don't mind saying who you are and whether you represent an organisation. My expectation is that after Nick's 10 or 15 minute presentation, when we get into questions, we'll probably have the first hour dealing with questions. Clearly the board will be hearing what's said, and then at the end of that part of the meeting, I'll be going into more kind of formal committee mode behind the desk, chairing that meeting when the non-executives and executives will be considering the business case and also asking questions of one another on the case itself. And at the end of that process, as I've said, the board separately will come to a view, and I'll explain how we'll do that later on this afternoon. In terms of those who want to stay for the afternoon, we should be most welcome all afternoon. My expectation is that we'll be here for just under 2 hours. So I hope that explains how I'm hoping that the events go this afternoon. But without more ado, if I hand over to Nick now, Nick will go through the presentation, and then I'll come back and take questions.
Thank you, Chair. Good afternoon, everybody. I'm delighted to be here this afternoon. I'm normally in this event as some sort of social, or this venue is some sort of social event, so I feel quite... Hello, Damien. So what I'm going to do is just to talk briefly about our ambition. The NHS is 70 years old in July, and there's nothing else that remains the same for 70 years. And given the demographic challenges, given the incredible work that our clinicians and others do in terms of the use of technology both for healthcare and other aspects of our lives, it would be remiss of any of us to think that the NHS is fit for purpose now as it was 70 years ago. The average life expectancy in Suffolk 70 years ago for men was 67. It's now 85. And yet the NHS hasn't reinvented or redesigned itself around recognising the increased life expectancy, which is fantastic, but that comes at some difficult decisions and some difficult conversations that we need to have about the NHS going forward. The country's been divided into 44 footprints, sustainability and transformation partnerships, which start to look at how do we reorganise healthcare to recognise that unless we see a significant investment of revenue over the next few years, or we radically reform healthcare and social care going forward, invest more in social care, more in primary care, more in community care, then the NHS simply will not be able to deliver the fantastic care that it delivers every day to over 1.3 million people across the country. So as part of that SCP and as part of looking at what both Colchester and Ipswich Hospital deliver, we've gone through the last 2 years really of thinking about how can we maintain the great services for local people on a local footprint. How can we recognise that there won't be a significant investment of cash coming into the NHS over the 5 years of the plan? How can we retain the best possible staff and attract the best possible staff to come to this wonderful part of the country? And how can we do that while maintaining, as I say, services that are local? And, most importantly, continue to deliver the high quality care that myself and my colleagues behind me are so proud of. So what I'd like to do is to just take you through some of our ambition in terms of where we want to get to as East Suffolk and North Essex NHS Foundation Trust. Yes, that was always not going to work, wasn't it? So, yep. Yep, I'm doing that. Yep. So you might have to work with me a little bit on this. There we are. There we are. Okay, so that is, as you can say, so, yeah, I really don't, okay. So, that's the wrong way around. So this is the footprint that I was talking about. It does cover 750,000 people that we have the privilege to serve across North East Essex and East Suffolk and Ipswich. People have been asking us, why are you doing this? Why are you merging the organisations? What's the advantage? And I suppose the most important thing for me is that we protect local services where that's appropriate. With radiotherapy, if somebody's unfortunate enough to need radiotherapy for cancer, we need to be treating a certain number of people locally in order to have the critical mass to assure our commissioners that we're as expert as we need to be in terms of delivery of that really important care to patients. Radiotherapy, as many of you will know, often requires up to 6 weeks of daily treatments, and although the treatment itself only lasts about 10 minutes, that's very disruptive for patients. Neither organisation independently would be seeing enough patients for radiotherapy to retain services locally. So in the future, with the new commissioning, people who needed radiotherapy to the south, from Colchester, would have to go to London, and from the north would have to go to Norfolk, Norwich or Cambridge. That is not right, I don't think, for local people. If you need specialist, ultra-specialist care, then going to centres of excellence is absolutely right. But for relatively routine care like radiotherapy, it's really important to myself, my colleagues on both boards, that we retain those services as locally as possible. Strengthening our services. All the services are under incredible pressure. You know, you would have seen, I'm sure, through the press over the winter, the enormous pressure that the NHS has been under and continues to be under. And I'm very clear, as being responsible for both organisations, that neither organisation can sustain that incredible pressure, particularly on non-elective care, on emergency care, without retaining more resource, retaining more staff, and thinking quite radically about how we can deliver care differently. We want to grow our services. We have to grow our services. The demographic growth in Colchester is the fastest growing town in the country. The hospitals, as we currently deliver care, will not be able to sustain that growth. So it's fantastic news that the Department of Health, only yesterday, the Secretary of State announced £69 million to be invested in both hospitals over the next few years, part of an £87 million investment in our local community, the second highest award in the country with this tranche of cash. That is a massive investment of confidence in our health and social care services locally, and will transform not only care in the hospital. I'm so pleased that we're also seeing a significant investment in our community hospitals, both at Clacton and Harwich, recognising that the hospitals themselves will not be able to accommodate the growth of activity that we're seeing. Okay, this really is not great. Okay, so when we first put together our plans, we said we'd see patients on time. That was our ambition. I challenged that and said, that's a really big commitment to make. So we've changed it to say we'll see patients at the right time. We know that a lot of the stress that is caused of being ill is unnecessary. If you're facing illness, then that is stressful. It's stressful for you, it's stressful for those who you care about, it's stressful for your families. We can't do much about that except support you with care and compassion. But what the NHS has got really good at, sadly, is just adding to that stress. Bringing you back for appointments that maybe aren't necessary, requiring you to come to hospital when a local community service could provide just as much good care as it can in the hospital. Making it really difficult for you to communicate with hospitals or with your GP. The fact that technology is so poorly used across the whole NHS in terms of accessing healthcare and information about healthcare. So seeing you at the right time means that we will only see you in hospital. Our ambition is to only see you in hospital if there's a clinical need for you to be seen in hospital. And if the right time and place is for you to be seen in the community, or maybe not even seen at all, the use of technology, the use of Skype, the use of email is something that we just haven't been good at in the health service. And what we're able to do with a much larger organisation is to really invest in technologies, really invest in ways of making sure that you're seen at the right time. The retention of staff is a really big challenge. It's been particularly difficult whilst there's been, let's face it, some years of uncertainty around the future of both hospitals. I've been at Ipswich, I'm very pleased to say, and proud to say actually, for 5 years next week. And 5 years ago, there wasn't a clear strategy about the future of Ipswich Hospital. We simply realised very early on that both financially and clinically it was not sustainable, and the same with Colchester. So that's quite difficult when somebody's thinking about, for example, a consultant or any senior clinician who's likely to invest the next 20 years of their life working in an organisation, to think, well, shall I go to somewhere whose future is a bit uncertain, or shall I actually go to one of the major teaching hospitals where we can absolutely guarantee that Cambridge and Norfolk and Norwich or the teaching hospitals in London will retain their services forever? And I think the statements that we're making, and we've been making for the past couple of years, but crucially making today, if the boards agree, the business case, is that we've got a long-term plan. We've got a long-term strategy. We've got a strategy and a plan that the government are prepared to invest £69 million in terms of moving forward. Retaining staff is crucial. And again, providing services locally, which I've talked about. I want to talk a little bit about accountability. David spoke earlier about the differences in governance between Colchester and Ipswich. At the moment, the people who use the services of Ipswich Hospital have very little or no say, no legitimate say, no legitimate challenge in terms of the way that we provide care. You might have a view, and I hear them often, and I welcome that. But in terms of any formal way of challenging the board, challenging the strategy, making appointments to the board, there is no legitimate way of doing that. The only way to get that is to be a foundation trust. And the bar around the financial success or the financial sustainability of an organisation means that Ipswich could never become a foundation trust. We'd simply never have the resource to be able to do that. If we merge, we become a foundation trust overnight. And overnight, local people have a legal say in the running of the organisation through the members and through the governors. So you can see here that we'll have four governors from Colchester and 5 from the county in Essex, 4 for Ipswich and 5 for the county. Staff, 6 members of staff, 3 from each side, will have the right to challenge the board to be involved in the insurance committees. And I know we've got some of the governors from Colchester with us today. And we will have people appointed from our local stakeholders, the universities we work with, the local authorities that we work with. So for me, if I was asked what was the main reason, the main change around Ipswich Hospital as opposed to Colchester, it would be that overnight local people will have a say, a legitimate say, in setting the strategy, holding the board to account, and the running of the organisations. This merger is the only way we could achieve that, given the current legislation. One of the only gifts that we can give to the people that we serve, to our patients, is that of time. None of us know how much time we have. Many of us are looking forward to a long and healthy life, but sometimes that just doesn't happen. And the time that we have is really precious. And what's important to me and to my colleagues is that we value time. That we take time seriously, that we don't waste your time. If you're over 75 and you're admitted to hospital for more than 2 weeks, you have an average of 1,000 days to live. I don't know anybody, if they were told they had 1,000 days to live, would say that they choose to spend it in hospital. People who are facing life-threatening or life-shortening conditions don't want to spend time in hospital, don't want to spend time with wasted appointments, don't want to spend time waiting on the phone for it to be picked up, don't want to spend time waiting to find out when their appointment might be. As that is the only commodity that we can give you, the only commodity we can never change or take back, it's really important as a new organisation we remove the unnecessary stress of being ill for you and your families, and we give you time, the most precious commodity that we can. So just to talk very briefly about the governance of the new organisation, there will be one board. Can I just, as David said, that it won't be all of these people, because that would be a nightmare to manage, believe you me. It'll be about half. I haven't told them yet which ones. No, I have, so no. So it will be about half the numbers. It will be a manageable, at least in theory, group of individuals. So the board, the Council of Governors that I've talked about, we will integrate all our corporate functions, and there will be a saving, there will be a financial saving out of that, where there is duplication, where it's not necessarily. We'll have clinically led divisions. One of the real benchmarks of a well-led and a well-functioning organisation is to see clinical leadership at the heart, not just at the board level with the director of nursing and the medical director, but to see clinical leadership at every level in the organisation, listening to how clinicians want to work, listening about how we can, for example, release time for staff. Because there's unnecessary stress for staff, and there's time that we can release to staff back to care for patients and not be caught up with unnecessary bureaucracy. The care delivery groups are the next level down. So, for example, A&E will sit as part of one of the 6 divisions, but will be separately run across both sites. And some flexibility within that. We know there are different pressures at different times of the year in Colchester and Ipswich, and allowing to move staff, using the experience of both organisations. And we've seen that this winter, just by sharing the experience, sharing some of the knowledge. Both Ipswich and Colchester have been the best performing A&E departments around the 4-hour target in the east of England for the last 6 months. That's an extraordinary turnaround from where we were even just a year ago. A single vision, which I hope I've been able to explain and display to you today. Happy to take questions. A shared set of values, one budget. That's important. You pay our salaries. It's really important for me as a steward of your money that we spend that sensibly. It's valuable. We need to spend it sensibly. We need to manage that budget as one. 2 distinct acute hospitals. I don't expect, if you stopped somebody who worked in one of our hospitals in 6 months' time and said, where do you work? They won't say, I work at East Suffolk and North Essex NHS Foundation Trust, or ESNEFT. They'll say, I work at Ipswich Hospital. I work at Aldeburgh Hospital. I work at Colchester Hospital. I work in the community. I work in Harwich. We need to maintain that identity because both organisations have a strong identity, a recognisable identity, an identity that both staff and patients are proud of, and we need to retain that. And finally, a foundation trust where you can get involved. Hopefully you're all either already or will become members of the new organisation, members who have the right to vote for the governors, the Council of Governors, and therefore have some say, some democratic say in the running of the hospitals. Just want to say a little bit about how this fits in terms of the ambition around the STP, which I also have the privilege of leading locally. We know that we want to keep people at home for as long as they can be and keep them as well as they can be. Hospitals are horrible places. They really are. You know, we make them as nice as we can, but they are awful. I've stayed in some awful hotels in my time. I've never had to share a room with 6 people and share a bathroom. The food's not great. You know, you usually lose so much of your dignity. So you should only be in hospital if there's a clinical reason for you to be there. We really don't want people to be in hospital, and you as patients and the public don't want to be in hospital unless you need to be there. Allowing people to care for yourselves. There's so much we can now do with technology. There's all sorts of IT now that's being used with people to self-monitor, people with COPD, people with diabetes, people with heart conditions, being able to monitor their condition themselves on a daily, hourly, minute-by-minute basis and only calling for help when they need it. We need to be exploring that technology. What have we heard? We've done a lot of engagement. We haven't done consultation because we haven't been required to because there were no significant changes. And these are just some of the questions that we've heard. Will services move to other sites? Possibly, but only if there's a clinical need or an access need. And what I mean by access is a shorter waiting time. If there's a really good clinical need to centralise services on one site rather than the other, we will consult. We are bound to consult through our colleagues at the CCG, the commissioning group, to consult with you as the public about what your views are. And we would take them into account before we made any decision. If there's a shorter waiting time, if we're able to invest in services differently, we haven't made all the final decisions around the £69 million investment, but it may be that we centralise services on one site rather than the other, because it means, for example, that we'll have less cancellations. If we're able to protect the elective pathway, the planned care pathway, the operations, if you like, that are planned, from the non-elective, from the emergency work, we'll have less cancellations. It's a real problem in the winter about how you manage the waiting lists, particularly when you're overrun with emergency admissions over the winter and increasingly over the summer. We don't want to travel long distance for care. This is an issue now. It's mainly a rural population that we serve. So travel is a really important issue. And the first question I always ask is, did you need to come to hospital? Was there another way of providing that care that meant you didn't have to travel or get community transport or ask a family member to bring you to the hospital? Ipswich is much better than Colchester and risks getting dragged down. We've heard that a lot over the last 2 years. Colchester is in a much better place. All the indicators have improved significantly over the last 2 years due to the extraordinarily hard work of the staff that are working there and through the support of our partners. People will always believe that one organisation is better, there's a bit of pride in there and everything else. There is absolutely no evidence, and we've seen over the last 2 years that Ipswich has maintained and even improved in some of its indicators, despite the fact we've been working in partnership, or possibly because of the fact we've been working in partnership for the past 2 years. Benefits to patients are really important for staff. They're really, really important that we get this right. It's really important for me in terms of leading the services locally, that we provide the best possible care to you and your families. We've talked about, staff are concerned about travelling. It doesn't make a lot of sense for me to pay staff to sit at the Copdock roundabout. I've got an intimate knowledge of the Copdock roundabout now over the last 2 years. I know every stone on that roundabout, it feels like. And I know how frustrating it is and how much time I've wasted, frankly, and I don't want other staff to be doing that, particularly clinical staff. So we will keep travel to an absolute minimum if required at all. And are we reducing staff? There's probably not a journalist in the room or outside the room that won't at some point ask me, what does this mean to redundancies? I don't know any leader of a public or a private sector organisation facing the degree of challenge and change that the NHS is facing who can guarantee there will be no redundancies. And I won't give that guarantee. What I will say is that we have a turnover of about 10% a year, which is about 1,000 staff, moving through both organisations over 12 months. And every time that a vacancy comes up, we'll have a good hard look at that. So posts will inevitably go. It doesn't mean that people will go. And we will only use compulsory redundancies absolutely as a last resort in terms of the change that we face. Thank you very much for listening.
Thank you, Nick. Thank you, Nick. I hope you agree with me that Nick's been very clear in setting out the bones and the rationale behind what both boards have been building up to today's decision about merging both organisations. The final slide started to get into some of the questions that have been raised in our engagement exercises over the past few months. By all means, reiterate them again, build upon them. So I'm going to open it up for questions, and if you're okay, as I indicated, if you don't mind saying who you are, and then I'll decide who best should answer it. And we're doing all right for time, so we've probably got a half hour or so for questions. But if we run out of steam, we won't prolong it. But by all means, if you indicate by a hand, and then I will try and manage the room. Okay, I think we'll let's tell you what we'll do. I'll come to you, but we'll just work this way. The first question. Shane, can you? Right. Yes.
Hospital. House. Private 112 Neptune Marine of Ipswich, Suffolk, England. Will they change name?
So the new organisation will be called East Suffolk and North Essex NHS Foundation Trust. The name of the hospitals won't change.
Why?
Because I think so we need a name for the new organisation, and I think it's really important that both hospitals retain their names and their identity. I see the new organisation almost as being a corporate holding company for not just the acute hospitals but also the community work that we're providing. So I think we've got the name of the organisation to reflect the community that we serve rather than the buildings that we work out of.
Thank you. One more question. I'll come back to you at the end if we have time.
I don't understand.
So shall I pick this up with you afterwards, because there are other questions.
I'm sorry.
That's fine. So if I pick up this with you afterwards, because there are other questions to ask, and I can go through the rationale for the name with you. Is that okay?
Yeah.
Okay. I'll catch you afterwards.
Hello, I'm Julie Young. I'm an Essex County Councillor and a Colchester Borough Councillor. I think you started talking about the good news of extra financial resources coming to this area, and then you ended talking about redundancies. What worries me is every change within the NHS costs money. This will cost money. So I can't actually see what the benefits are rather than continuing with a collaborative arrangement. You've talked about IT, you've talked about structures. What actually we need is extra capacity, and you ended your presentation saying you were talking about redundancies, which I think worries us as patients. I was in Colchester A&E on the 19th of February. There were 2 nurses working in A&E that day. I was there for 6 hours. What I was told is there should have been 4 and there's 2, and I'm worried by how you ended this presentation.
Thank you. I'm going to bring someone in, but in fact, what Nick was very clear about was that he couldn't rule it out, but we don't have a plan as part of this to look at a certain number of redundancies. What Nick was clear about is that we have across both sites, both hospitals and the community services, a natural turnover. And one of the key drivers with regard to why we think coming together is important is actually about protecting those frontline services whilst reducing, and we do need to be a formal organisation to do this, reducing some of the duplication in terms of some of the services really from the board downwards. But Nick?
So I cannot envisage a situation where we'll ever be making clinical staff redundant. Just in terms of what I said about the growth, just in fact that we've got a 10% vacancy factor in many of our clinical staff at the moment. The challenge with staff is just that there aren't enough trained nurses because of the way that we've educated nurses for the past 20 years. It's really difficult to attract junior medical staff out of London who are attracted to work in London. So the challenge for workforce, which we deal with every day and to provide safe care, isn't about the ability to pay for them. It's about whether or not they are there, whether we've got the post there. The reason I talked about redundancies is because that's what I've been asked when we've done the engagement piece. So I cannot envisage any time in the future where there'll be redundancies of clinical staff.
And I think also, if I just may, as a county councillor, you will have experienced over a number of years having to manage priorities within the cash that you're able to raise and receive. The same is true within the NHS. Clearly, we could spend more if we got more. So we have to try and live within our means, which is incredibly difficult. And certainly some of the overhead costs, if I can call it that, we will be able to reduce. But just on the finance, can I just bring Dawn in as the Director of Finance to see if you want to add anything, Dawn?
Yeah, I think it's important to say that the full business case focuses on how we can reduce our corporate costs, which is what the basis of the merger is on that we're discussing today. In terms of what that means for clinical services, it means that it reduces our deficit associated with the provision of hospital care, of care across the new organisation. It means we can invest more then in frontline services. So that's our focus around the cost reduction.
Thank you. Just moving across. Yes, okay. So I'm going to sort of, if you're okay, you had your hand up first. Look, let me take you because you had your hand up first, but then I'm going to do it more systematically, sort of front to back across. Okay. Thank you. No, it's behind.
Hello, my name is John Krieger. I'm speaking on behalf of Suffolk People's Assembly, which is an organisation that has organised, I think, 3 national demonstrations in defence of the NHS in the past 2 years. I think the last one we took about 70 people from Suffolk along. Now, first point is I'm not in any way opposing a merger of the 2 hospitals necessarily, and I'm not against integrated care. However, there are some quite major issues around what the term integrated care system actually means, in particular the ones that have been raised by the judicial review that was brought by professors, the late Professor Stephen Hawking, Alison Pollock and et al. I won't go through the whole list of names, which challenged Jeremy Hunt over the issue of consultation. And the whole basis of their argument was that, in fact, you know, and this was a reaction to it, the introduction of the term integrated care system became a euphemism for what had been previously known as an ACO, or accountable care organisation. And their submission was that this was a major change to the NHS because it involved bringing together private providers with a state system, the devolution of the NHS to local trusts and so on. And it was a form of privatisation. So effectively, we're in a period now where there's a 3-month consultation period. We're still actually in that, where Jeremy Hunt had to go back and carry out effective consultations. And their contention is that during that period there should be no sign-offs on anything like an ACO, which I contend the ICS here is going to be. In Cornwall, the local council, which was Lib Dem and Labour, rejected such a system. Okay, so that's the first question. And this is one question, 3 minor parts. Is an integrated care system actually a euphemism for an ACO, which is a different form of NHS system? The second part of the question, I need to actually read this with reading glasses on, is, I'll speed it up. Which private providers are amongst the partner organisations mentioned on page 31 of the final business case? Because there is, I mean, that's important to know because there's evidence that privatisation fails to provide adequate treatment and patients get discharged before their course of treatment's been completed. Third one, if the ICS is really just a euphemism for an accountable care organisation, doesn't this represent a major change to the 2 hospitals, and therefore shouldn't there have been a full public consultation? Yeah. So I would argue that to actually sign off the current plan in the 3-month period while the consultation has been ruled by a court is not really the right thing to do.
Okay, thank you for the question. I'm going to start, then hand over to Nick.
Yeah, okay.
But Nick gave a context to the work of the 2 organisations. To be absolutely clear, this is about 2 separate statutory organisations providing acute services and acute and community services coming together. It is not in itself an integrated care system, but Nick.
So yeah, just to reinforce that, so there is work around an integrated care system. It's not a formal structure. It's a group of partner organisations coming together to work differently, all with their own sovereignty. There's no new board, there's no new, so every organisation still retains its own independent decision making through a board of directors. Some are FTs, some are not FTs. So we are looking at working differently. We're looking at concentrating on people, not organisations. We're looking at working for the population we serve, not for the people who happen to be in our hospital or in our GP practice or in our community hospitals at any one time. So that is the work that the STP are leading at the moment, but it's not to create a new organisation, it's to create a different way of working among a series of organisations that retain their independence. In terms of your question, I'm sorry I don't know the exact, somebody's just handed me page 31, I don't know. So there are some third sector organisations involved in the work that we've done, the voluntary sector, and I think sometimes people say it has to be all NHS without recognising the work that Macmillan do, for example, the work that our hospices do. So I think in terms of defining what's NHS and what's third sector or private sector, we need to be clear. So there are no private companies with shareholders involved in the ICS at the moment. Okay. Is that helpful? Does that answer your question?
Okay, thank you. I'm going to move on because there's quite a few questions and I will get to everyone. Okay. Sorry, we just need the microphone to get to you. Yeah, I've logged it. It's okay, I'll come to you.
I think my questions are quite simple ones. Is the £69 million that you've mentioned, is it over the next few years? How many years are we talking about?
So, the money has been awarded now. I doubt we'll spend it as quickly as, so we have some broad plans which Paul Fenton, who's our Director of Estates and Facilities, has been working on along with colleagues at Colchester previously. So we have a plan. It's not perhaps as detailed, so I can't give you an exact phase plan about exactly how the money will be spent. But if there's anxiety about it being spread over too long and then it magically disappearing at some point, that won't happen. All the money has been, all 87 million has been awarded, both for the hospitals and the community.
And are they for capital projects or what?
It's all for capital. Yes. There's no revenue involved in that. And the money, as I say, is split between the community and the two acute hospitals.
Excellent. Thank you very much.
Okay.
Thank you.
I think there's a question behind. Yes, I have logged it, so I'm going to work my way through. Okay, there's a question at the back.
Hi there. My name is Anthony Dooley and I'm a member of Suffolk Unite Community. We oppose the STP. It's a process about privatisation of the NHS and its demolition. You quote in the document about the mission being to reflect that of the NHS at its foundation and is to continue to follow the principles identified in 1948. Then you go on to explain what that means. I would like to suggest that what you explain its meaning is not actually the full meaning. You say this means providing healthcare and services that meet the needs of everyone, free at the point of delivery and based on clinical need. I think Anarin Bevan would be turning in his grave if he thought that was what the message from 1948. It was about a national health service with the emphasis on the national, not about breaking up England into 44 little units, which eventually could be transferred to private sectors, especially in the United States. So I would suggest that I understand, for instance, that Jeremy Hunt has now scrapped the national targets, the three main targets, that's correct? Both hospitals at the moment fail on those. So what better way to not inform the public about the quality of the service by actually dropping the targets?
Okay, thank you. Nick will pick up the targets issue, but very quickly, we deliberately designed it so it's an open meeting, so clearly you can raise any issue. Can I say that the board collectively work within the present system, and we don't necessarily, as a board, determine both the views and certainly the policy that we work within. So, in fact, you make, I think, a political statement, which is absolutely fine to make. We're actually concentrating today on our statutory responsibilities to look at what we believe is best for the local population for the provision of health and community services going forward. Nick?
So, just to comment on that. So there are hundreds of years of experience in the NHS behind me, literally. And I know each and every one of these individuals is as committed to the 1948 NHS Charter around care-free at point of delivery as I am. If you cut these people's arms, they bleed blue. We're committed to the NHS. If I thought for 1 minute the STPs were anything other than a way of truly trying to serve our populations in a different way, I'd walk away from it tomorrow. And that's my personal belief, and I know the belief of all my colleagues. In terms of the targets, I think the relaxation of the targets is a recognition from the Secretary of State that to keep beating us up and ask us to run faster and jump higher against targets because of demographic pressures, because of reductions in funding, particularly in social care, are unable to achieve them, benefits nobody. I think he's taken a pragmatic, I'm not going to comment on whether I agree with him, but I think he's taken a pragmatic approach to realising that we have to prioritise on quality, on safety, on clinical outcomes, and not be obsessed by targets, is my view.
Thank you very much for your question. I'm going to move on because there's quite a few others. Can you take the microphone? And who's next? Please, yes, this lady. Shane at the front, this lady at the front here, and we'll move back.
Inga.
Yeah, Good afternoon.
Hello, I'm Inga Lockington. I'm a borough councillor and a county councillor, and then I have been married to the health service for 38 years. So I think I know it a bit for as long as Nick Hune has been involved with it.
You haven't been married to me for 38 years, though.
Not you,
yes, that's
but,
right. Just so we're clear.
Yes, but I have been married to somebody else in the health service. Indeed. Now, a quick question about the elderly people staying long-term in the long time in the hospital, which Nick mentioned. One of the things you need to change to is the system behind it, because it's about the tick boxes that need to be filled in before they can start to be looked at as ready to go home. Yeah. So it's not about just getting the, the care right, which you can get, but it's the whole tick box system behind. Yeah. Because it's absolutely right and devastating when elderly people want to go home, but they can't because of the tick box system. Yeah. Yeah. And can I add a very quick one to the capital we talked about before? Can you clarify 100% that it is pure capital and not just allowed to do another PFI project?
Okay, I'll answer both those. So I think in terms, you're absolutely right, some of the paperwork that clinicians have to spend their time filling in is a waste of time. And I think that we recognise that from the local authority, we now recognise it very much in health. We have to be safe and agile. So we have to make sure that we're making the right assessment, that we're providing the right care, whether in hospitals or outside hospitals or patients, but we need to be much, much smarter. We need to use technology. I look at paper books of 30 or 40 sheets just to get somebody once a day domiciliary care. It's a nonsense. I think we recognise that from the commissioners, we recognise it from social health and social care. And again, one of the advantages of working across two counties, that we take the best ideas from both. One of the advantages of working with twice as many clinicians is you've got twice as many brains in the room to try and fix this. So I think you're absolutely right. Yeah. There's no PFI involved in the capital. Okay.
I'm just going to want to bring members of the board in, although trying to manage time and stuff. So any quick observations from nursing medical on that? Angela.
Thank you for your question. I'm Medical Director at Colchester, Dr. Tillett, Medical Director at Colchester. I think you raise a really important point about when we're trying to get our patients home, and I think it has become a bit that we're very safety conscious, but sometimes we're not asking our patients what's important to them and to those close to them. So I think actually moving forward, working more closely with our social care partners, our CCG partners, trying to break down some of those barriers. And I think there's been a lot of joint learning we heard earlier on between the different hospitals, which is why we've managed better through the winter months, trying to sort of bring about get our patients where they want to be. But I think you raise a really important one. There's always more work to do, but that is certainly an area of focus, and we've learned from both Ipswich and Colchester sites how we can do that better.
Thank you, Anja. I'm going to go to a question at the back. Yes, this lady, Shane. Yes, we'll just give you a mic, if that's okay.
Hello, I'm Linda Fravigar-Monday. I'm a service user with the Wellbeing Service, but I also use the hospital, the Diabetes Centre and rheumatology. My concern in some respect is the foundation, being part of a foundation trust. Recently we have combined Suffolk Wellbeing combined with Norfolk and became sort of in partnership with them. We've found in Suffolk that the problem we've had is a lot of the services have actually been taken from Suffolk and now are in Norfolk. So if we need particular if we need to go to meetings or what have you, we have to go to Norwich. And I understand what you're saying about Essex is much closer, but I'm also making the point that we need to make sure that problems that we have here or pluses that we have here are actually counted in both areas. The other thing is the question of information technology as well. I actually work as part of I don't work actually, I'm actually a part of a peer support group. We have meetings for our well-being, and those are boosters to actually keep us going. Unfortunately, again, with Suffolk, we now have most of our courses are now webinars. They're online. And that's all very well for people who are computer literate. I hope I am actually, but there are people who aren't. And we've noticed that a lot of people now are finding it more difficult because they have not got the access to the services that they really require. Can you please, all I'm saying is please, can you make sure that not everything goes automatically online straight away?
So just on both those points, I mean, firstly, as I said earlier, if there are changes in services, which I think will be an absolute minimum, but if there are, we will consult. So we'll absolutely understand where people are, what it is that they need from the service, and the best way that we can provide them. I think you make a really strong point around the digitisation of health. It's not for everyone. And what I'm absolutely committed is to wherever we can provide that whole portfolio of how people interact with the health service face to face, online, so that and as we release some resource, some staff in terms of going to more online, then it will allow those staff to support people who need the face-to-face support. So we've got some clear ideas about that. Technology is fantastic if you know how to use it. It's a nightmare if you haven't got it. So we do recognise that, and we have been talking to different groups about what's the best way to communicate, what's the best way to interact with us as the providers of healthcare so that we can best meet your personalised needs.
Yeah, thank you.
Can I just say finally, please, it's to do with the accountability and people's opinions being held. Again, with experience of a trust being sort of put into foundation, we now have, from the wellbeing, there is no user forum.
Well,
can I please ask you, it sounds very good, the Colchester, the Essex sort of governance seems to be a far better working.
And of course that will now be reflected in Suffolk through the Foundation Trust, but it doesn't mean that we'll lose, for example, iHug, the Ipswich Hospital User Group, which does fantastic work in terms of being part of our decision making. in a sense it formalises that and it holds us to account in a better way. So I think the great work that our governors do at Colchester will be reflected now at Ipswich through governors who are elected for the town and the county and the stakeholders. But bringing all that accountability together is really important.
Yes, because sometimes, obviously, sort of, if people are actually have good points to say about how the strategy is working,
absolutely,
it's important, and you can actually build upon experiences where people say, "Oh, this didn't work very well."
Yeah.
It's not a criticism.
No. It's
a case of building a more appropriate and much better service.
Thank you very much. And just to say, and Richard, do you want to stand up? Because Richard, Nick mentioned iHug, which is the Ipswich Users Group. It's nationally acclaimed in terms of patient engagement. So have a chat with Richard after the meeting, because we are determined that we get the best of both. So we get the best of the Colchester governance model, and we get the best of the Ipswich patient user experience too, because it's very, very, very good, very extensive. Thank you. Lady, you've been very patient. I think it's on.
Hello.
Hello.
Hello, my name's Jan Plummer. I'm representative of the Colchester People's Assembly, and last year we held a march of nearly 1,000 people through down Colchester High Street in support of a publicly funded and publicly delivered NHS service. I've read the business case, and what really comes across to me is that it's very good on clinical excellence and reduction of costs, perhaps reduction of costs, but on clinical excellence in particular, but very weak on putting patients first. And some of those patients, a lot of the patients who use the NHS, for example, have no car, they have no relatives, they have no spare income to spend on extra transport for travelling extra distances. And when they need expertise care, which is won't be available at local level, they are sick and they have to travel longer distances. So that's the sort of observation about the business case. On page 58, 5.61, you've made 3 statements about sharing services across the 2 centres. And the first one is sharing access to some emergency theatre lists. The second one is spreading emergency rotas across sites. And the third one is provision of 24/7 emergency service across both sites. What I'm asking is in relation to patients and staff, does that mean that at one point in time there will only be a service on one of the sites for all those 3 things, and does that mean that patients will have to travel longer journeys to access emergency care?
Thank you, Jan, and for that. And I know that you've been following, because you were at when we did the outline business case, you came. So thank you for your continued interest. Just as a comment before I hand over to Crawford, who's the medical director at Ipswich, I don't know if he wants to comment, and Claire Marks, who's also been helping associate the medical director on this. I think I'm surprised, because what you say, we are genuinely wanting to put patients at the heart of this. So if we haven't got that right, then we've got some more work to do, but we believe it's strong. If it's not strong enough, we'll pick it up. But Crawford, then Claire.
So thank you for your question. I think it's essential to everything we do. The patient focus, the patient experience, and the outcomes we get will define our success. And we won't achieve that if we don't listen to patients. So I apologise if the impression was not that it's patient focused. It most certainly has been in its inception, and it will be as we roll this out. One of the important things to say as a ground rule is both hospitals will have emergency services. They'll have emergency departments, and they will have a medically led midwifery unit, a maternity unit as well. Those are written in principle. As Nick has said, we don't want staff going up and down the A12. Neither do any of us want patients going up and down the A12. We've talked about the fact that certainly care closer to home really matters. And there are patients who need emergency care who in the old system would have had to come to the emergency department but are now seen by innovative teams such as our REACT team, and sometimes get care right in their home or very close to home. That's a really important part of the principle. Not everybody needs to come to hospital with some emergencies. We're clearly going to have 2 emergency departments, but medicine has become a lot more complicated. And we know that the need to provide the best care every day of the week, every day of the year, would be what all of us would expect. We want to be able to get the specialists who patients need to see in times of complex illness there to see them every day of the week. And by pooling our resources, by using those specialists, again, I don't want them travelling up and down the A12 when they don't need to, but by using those skills and covering gaps and thinking innovatively, we know that we can give better 7-day care to patients as close to home as we possibly can, but never compromising quality, and giving them the best outcomes, the outcomes they would expect in the best centre of excellence, but in a way that is listening to what matters to them, but always keeping safety and quality first.
Thank you, Crawford. Can you turn the mic off then, Claire, if you wouldn't mind comment?
Thank you very much. It's interesting, at the moment we accept the fact that some of our patients have to go to Addenbrooke's or to Papworth for their cardiac interventions, for their heart issues. And one of the real benefits of this is that we may now be serving a larger population, and we may be able to provide some of those services actually back here in this area. So rather than actually some people travelling more, some patients and their families may travel less. The other interesting thing is that as medicine has become more specialised, we know that we have to create small areas of excellence. And for the last 5 years, patients have been travelling from this area to Colchester for their vascular, for their artery surgery. And that has been done by patients coming into Ipswich and then, if necessary, being transferred. So we already have services where people are moving between the hospitals, whether it be moving to Colchester or in the past moving to Papworth. And those are the things that, as we come together, we can create new services and strengthen the services we have.
Thank you. I'm conscious of time. I've just got to... I'm going to take those questions, and that's, I'm afraid, the end of the public session. So I've got 5 quick questions, working from the front.
Thank you. I'm Victoria Weaver. I'm but a humble activist from the Colchester Labour Party, but I have strong views on this. First of all, I just want to say my view on it. I think that there is a dubious track record of hospital mergers across the country in the last 2 decades. It's not a new idea. It's not innovative to me. I don't know why it is happening. So why is a merger the best option for 2 different locales? I mean, Colchester and Ipswich are 2 different towns. We've got 2 different populations. Why is it good for them? And I'm appalled also that we couldn't guarantee no redundancies. Can we not even guarantee that we will work to make sure every worker, every doctor and every nurse can keep their job, even if it does mean there's going to be a few? Can't we not guarantee that we can at least work to make sure everyone can keep their job? And I think if Jeremy Hunt is listening today, I would say stop the mergers now.
Okay, thank you. Nick.
I mean, I think you're absolutely right. There is a long history of failed mergers. And I think that, it happens, I think 80% of mergers in business fail and a significant number of hospital mergers fail. And I've worked in organisations that I've joined post-merger and they've been a disaster. And I think they've been a disaster for 2 or 3 reasons. Firstly, there hasn't been a clear plan. There's often been driven together through failure. So 2 failed organisations put together that they'll magically become a successful organisation. They've been over-ambitious in their plans, and they haven't involved or engaged the staff or the public in terms of that planning. And I would argue that we've done all of that. So we have engaged the staff and the public. We do have a clear plan and a clear strategy. We can see that we're retaining services for local people, as Miss Marks was saying earlier, that already people from Manningtree who previously went to Braintree are coming to Ipswich. So already we're seeing that. And I think the other thing is that this process has been clinically led. So it hasn't been a group of suits sitting in a room thinking about how we can merge the organisation. It's been talking to Claire and to Crawford and to Angela and to Barbara Buckley, who's been leading on the clinical integration, to say what works clinically. So it's clinically led, there's a clear plan. I think so, and I think in terms of redundancies, I mean, as I said, I cannot envisage a time where we'll ever be making clinical staff redundant. Half of our staff are non-clinical. I'm never going to say never, but I can never envisage a time where we will be making, as I look at things at the moment, clinical staff redundant. Thank you for your question.
Thank you. Yeah, I've got just behind, straight behind, the lady straight behind then.
Good afternoon, Caroline Hennessy from Unison. Thank you for your presentation. Your plans for the merger are very ambitious, especially by the date of the 1st of July, which has been given. Given that this is going to be the biggest trust in the region, serving a population of over 390,000 people, I'm asking what is driving the pace of change for the merger at the current time, and also if the boards are going to sign off on the plans this afternoon, whether they would consider not putting the date on it until there's been further consultation and engagement with staff and public over the plans.
Okay, so thank you for your question. In terms of the dates, we are aiming for a summer merger, but if I just explain, so this has to now go through a process. So we'll sign off our full business case today. That then goes to our regulators, who are called NHS Improvement, and they will look at it, and a whole range of whether or not the business case stacks up financially, clinically, does it meet the ambitions of the NHS as we see it today. If they approve it, and it's a very rigorous process which will start literally next week, then it will ultimately have to go to the Secretary of State for sign-off. So it's not just us making a decision, then it happens. There are a range of filters and authorisations that we have to go through until that's ultimately approved. I think that we have engaged with lots of people. Just yesterday we had 60 people at a local meeting. We've had 130 people. Okay, Damien, we'll get to you just afterwards. But so I think we have engaged, and actually the advice we've been given is that we've engaged an awful lot more than any other merger, with staff and with patients. And I think there's a kind of cut-off point. It doesn't mean, and in fact it absolutely doesn't mean, if we then change anything as a result of the merger, we would then go through a full consultation and engagement process if we're going to change things clinically. So that the door isn't shut in terms of engagement, but I think we've gone as far as we need to in terms of engaging people around the FBC, or the full business case, until it gets into its approval phase. It may be that the NHSI come back and say you need to do more. It may be the NHSI come back and say there needs to be more clarity around the clinical strategy. And that kind of almost independent assessment of the business case, we really welcome that. Thank you for your question.
Question behind, the gentleman in the red. Thank you.
Yes, thank you. My name's Richard Bourne. I'm not here representing anyone or any organisation today, but I do work extensively for Unison. But to be fair, I also work extensively for the Department of Health and the major NHS national regulatory bodies, mostly on case evaluation and looking at full business cases and so on. And I've shared my reservations with the authors about the template you use, which is not the official 5-case Treasury template, but is some horrible cut-down version, which is why I think there are some limitations in that document that simply haven't been addressed. The strategic context is very poor. There is actually very little other than a smokescreen, because very little is identified which is actually crucially dependent on the acquisition and couldn't be achieved by other means. Now, I think that's in part a failure of the documentation rather than any intention, but it is a weakness. And it certainly doesn't address the excellent point made by my colleague that the evidence is overwhelming that these things do not work. They do not achieve what they claim that they will achieve. Okay. And it is overwhelming. And you haven't overcome those reservations. Right. Could I just make an observation that I think this format is dreadful? It's a terrible way of engaging with people. Just allowing people to ask questions is far too restrictive. And I cannot understand why you're taking this decision during the PERDAR period for local government elections. It should not be allowed. It's normally banned by NHS guidance. My question is, will you follow the excellent example that was set on Tuesday by the 3 clinical commissioning groups who were planning to merge. And they were going to take the decision to forward their process on Tuesday. And they listened to the stakeholders that turned up to their meeting, who managed to find out about it only at the last possible minute, I might add. And they persuaded those people not to rush ahead and to do far more work in engaging the stakeholders, and in your case, I would say, far more engagement with the staff and staff representatives, because this is a huge change with huge risks. And if you don't take everybody with you, then the almost certain failure will become an actual failure. Thank you.
Okay. Thank you.
Thank you for your comments.
Thank you for your comments. I'll pick up some of that, and Nick will sort of fill in details. But I think it's clearly everyone's coming with a particular view. This is something, and to reiterate, if you look at how extensive both trusts have engaged on this process hitherto, I would challenge what you're saying about that lack of engagement. And secondly, in terms of the merger being unsuccessful, and often, and you use the words about acquisition, this is a coming together of both boards that genuinely want to form a partnership. It's not a takeover. There are some technicalities around that, but it's a coming together of both boards who genuinely want to succeed. And I think that the sort of final point for me, and Nick will then pick up the broader issue, is it remains to be seen if our case passes muster, because we believe in the proposals, subject to the board confirming that later on, but it's our regulators who will judge us, and clearly, given your experience, you will know that they have their own templates and approaches to assessing the robustness of the case. But thank you for your comments, Nick.
Just a couple of comments. I'm going to ask Ali Bailey, our Director of Communications Engagements, just to very quickly outline the engagement that we've gone through. Just for clarification, the paper that went to the 3 CCGs wasn't proposing merger. It was proposing collaborative working with 1 accountable officer. 2 CCGs did agree to that, and 1 deferred the decision for a month, just for that clarification. But in terms of the engagement, Ali, could you just briefly outline the work that we've done?
Hello, yes, thank you. So we've been engaging really around this merger since January 2017, so this has been going on a long while. We've made a huge effort to engage with our audiences during this process, and we've got a huge amount out of that process ourselves. It's enabled us, given us an impetus really, to get out of the hospital and our offices and go out and talk to various groups that represent the special interests of our patients, and also hold drop-in sessions with the public. And in running that process, we've shared our plans and agreed those with the scrutiny committees of Essex and Suffolk County Councils. So we've asked people along the way, do you think this is the right way of going about engaging people? So we have tried to do a number of different things along the way. We've used some digital media that we've never tried before. We've held meetings as publicly as we can. This meeting, there was a meeting in Langham when we agreed the outline business case. And throughout the process, we've been holding board meetings in public. So we are trying our best to be as transparent as we can, but also listen to the people that we're here to serve. We can always do more, but this has certainly been a sort of step change for both organisations, I think, in running public engagement programmes.
I think the final point is just to say that it doesn't end here, in the sense that if both boards separately want to proceed on this, then that kind of engagement process will continue to develop. Because from what the Chief Executive said at the outset, we want these organisations to be very transparent, very open, and working with patients to improve the services. And I won't go back through the key points of the business case. 2 more questions, and I'm going to call it to a halt. So, at the back. And then, Michael, you can have the final word.
I'm John Ellison. I'm a Suffolk resident, also Secretary of the West Suffolk Trades Union Council. I'd just like to ask this, based on looking through the papers for this meeting. A large factor which supports the recommendation seems to be in relation to the substantial financial deficits, which I put down to fairly obviously underfunding, not to abuse of financial management. But the recommendation seems to be, in part at least, that a merger will cause the underlying deficits overall to reduce, those still to be very significant over the next 5 years. If I have that summary correct, that does look to me like a damage limitation argument, and that further damage lies ahead. Would you agree?
So I think if you look purely at the hospital, the provider sector across the STP, the 1 million people that we serve across the STP, you're absolutely right that if you look over the 5-year plan, that the hospital sector, the provider sector, does end that in deficit. But what balances that out is a significant surplus with the commissioners. So although you're absolutely right, even with the work that we've identified in terms of, as Dawn was saying earlier, the £22 million that we save over the 5-year plan of the full business case, it doesn't get us to a break-even position or a surplus position. But when you overlay the surplus that these commissioners will have over the same period, that does balance. And what we're doing as a system is moving away from, I often describe it as wooden dollars. I mean, it's all NHS money, and it seems to be, and has felt to me, bizarre, and as I've mentioned this to my commissioning colleagues over the years, to the point I've probably bored them, to sit with public money in a big surplus on one pile and a deficit on the other for the money that's there to serve the local people is madness, and they absolutely agree with me on that. We've got representatives from our 2 clinical commissioning groups in the room. So when we look at the system control total, and we look at how we're spending the money for the people that we serve rather than the deficit or the surplus that sits in an individual organisation, we do get to that balanced position. And the conversations that we're having now with our enlightened commissioners and indeed the local authorities is how can we stop some of this sort of feast or famine that we have in the NHS and in social care, and say how can we work together to look at how we're spending the Suffolk or the North East Essex pound for local people. So ultimately the STP does show the balance, but it's just in a different place. I hope that answers your question. Thank you for your question.
Michael, final question.
Thank you very much. My name is Michael Nimmy. I've been involved in health matters since 2003. I think most of the faces around the table are new. A few keep cropping up. Young David. But what I would like to say, I live on the Felixstowe Peninsula, and it's one of the many God's waiting rooms that this particular organisation you're proposing is there to serve. I look at the audience you have here today, and you've actually managed to attract less than 1 in 10,000 of the people that you will be serving. So I really do wonder whether your belief that you have engaged has been adequate. I went to the first public meeting in Felixstowe, and we asked a number of questions. I went to the last public meeting at Martlesham yesterday. The same questions were asked, and they were still unanswered. That really doesn't reflect engagement and growing and your knowledge coming back to the community that you serve. One thing that Nick said in his presentation was that the organisation that's being proposed will have one budget. So the question I'm giving to you that perhaps your financial folk can come back with, does that mean you will be directly funded from the NHS? Does it mean you bypass the CCGs, of which 3 need to come together to support you? Now, what I would like to say is that I'm extraordinarily disappointed with your engagement, particularly to those of my age who are analogue people. We tend to use the book, and probably, hopefully, I'll be able to do that until I go into my own box. This was presented to me or given to me by this young lady who I asked of it yesterday, and thank you for that. But it's a bit late for me to absorb this to question you. And it really is. And the question I need to ask is, at least in Suffolk, I don't know about Essex, I think they're in a different place, why wasn't this in all of our public libraries, or at least those serving main centres of population, during the whole period, so we could actually get ourselves informed, those of us who do not use the internet, don't really trust Facebook. We are very suspicious of all that appears and the amount of harvesting of our data that other people use.
Thank you, Michael. Thanks for those questions. So there's two questions there, Nick.
So just in terms of the budget,
Sorry, could I
we
just
won't
say,
be directly...
Can I remind both boards, we did have a merger of our mental health trusts on the promise that we would have a better functioning mental health service. Sadly, they're both now in special measures. You need to take that on board.
Yeah, thank you. Thank you for that, Michael. So I think just in terms of the budget, we won't be bypassing the CCGs because there's two people in the room that won't let that happen, Richard and Sam at the front here, and I think that's right. But what I hope I reflected in a previous answer was the relationship is now very, very different. It's not adversarial. We recognise this is public money that should be used for the public good, and I think for both Suffolk and North East Essex, the relationship that we have with our commissioners is the envy of many places across the country, and that's an absolute credit to a mind shift in terms of both of our clinical commissioning groups, but we won't be funded directly. In terms of the engagement, I hope I answered the question earlier that you're right, we probably haven't recognised that we've been over-reliant on the digitisation of our engagement process, and we absolutely take your points on board. I'm not going to get drawn into the ills or otherwise with the Mental Health Trust. That's not my place to do so. But what I can say is that we have seen a significant improvement around the quality and the governance at Colchester. As rated now, requires improvement and very close to good. Ipswich maintains its good recording, so it isn't either one or two failing organisations being forced together to the point earlier about merging. It is true two strong organisations coming together to be better than the sum of its parts and provide fantastic care to the 750,000 people who we have the pleasure of serving. Thank you.
Okay, and thank you, Nick, and thank you for those questions. So this draws to a close the public questioning of ourselves, the two boards. I'm going to go immediately. I recognise some people would like to stay and some people would like to leave. That's fine. But rather than having a break, I'm going to go immediately in to the board meeting with the boards. And just for absolute clarity, if there is not too much that comes out of that discussion, as you can imagine, both boards have been living with this and developing it and overseeing it for quite some time. But just to confirm what Nick mentioned, is that at the end of the meeting, subject to both boards' individual decisions, if approval is given, the next steps is this goes in to the NHS Improvements, our national regulators, who will consider the proposal as a first step. So thank you very much for making the time to come and for the questions that you've got. To emphasise again, this is not the end of an engagement. We genuinely want to find better mechanisms, and we do take the points that have been made, and we'll take those on board to continue the dialogue as we go forward. Thank you. Apologies for absence. Can we take the apologies for Colchester first, please?
Apologies for Colchester, Barbara Buckley.
Okay. Apologies for Ipswich.
Elaine Noska.
Right. Just can I remind all board members that if you do speak, can you use your mics and turn it off when you finish speaking, or I'm afraid I'll need to override you. Thank you. Declarations of interest. Those are, as noted, and there are a number of joint appointments, notably the Chief Executive and myself, but there are other directors around the table who are joint appointments with both organisations. Can I take those as given and as read? Thank you. We move to consideration of the full business case and the accompanying appendices. Nick has outlined the key aspects of the full business case, which both boards are familiar with. So rather than go through a presentation again, can I move immediately to questions from board members? And please could you indicate and perhaps stick your hand out, because there's a long line, and unless I move the table forward, I can't see everyone. Any questions from board members? Helen, and can you also introduce yourself as well, and then Diane after Helen.
Thank you. I thought that Nick would probably start off talking about the 70-year anniversary of the NHS, and I have an anniversary of working with the NHS later in this year, which to my shock, and I keep trying to add it up, but it keeps adding up to 40 years. In that time, there have been, I can't count, the number of reorganisations, restructurings, mergers, some of them positive, some of them with the benefit of hindsight, less so. But I think what I wanted to say, so it's a comment rather than a question, is that this, as I read this full business case, it felt quite different, and that the strength and resilience that I think we will have as the larger organisation gives some huge opportunities that are really exciting to provide better outcomes and services for people, and to deliver the philosophy, the time matters philosophy that Nick outlined. So I just wanted to make that comment, really. After a long number of years working in the NHS, this does feel different, and I think it's very positive. Thanks.
Diane?
Diane Leacock, Non-Executive Director at Colchester Hospital. I just had one comment and a question. Basically, the full business case, I think it's really quite sound, and the fact that it's clinically led really gives me confidence, because our clinicians are on board and will drive this change forward. One observation I've made, and as a comment I've thrown out to the board, the rest of the board, is that around engagement, because we have been engaging for quite some time now with our staff, the public, hard-to-reach groups and others. And we have continually questioned whether or not we have, engaged with the right people in the right way. And I'd just like us to think about that a bit more carefully, because a number of people have brought that up and I know we look at digitization and the electronic means of engagement, and that suits people of a certain age range. And given the population profile and the age demographics, we do have a number of older people in our population, and we need to also consider, perhaps, apart from the face-to-face, more paper. So it's just something to consider, so thank you.
Nick?
So, thank you, Diane. I mean, I think that we could never do enough engagement. I think even if we worked for 8 days a week, we'd still find it really challenging to get the level of engagement that we would all be happy with. I think you're absolutely right. We need to look at different ways of engaging people. I think also it's about, every time I get an email, I've found another group who I didn't know existed. So I think rather than trying to create new sort of feedback structures is to go out and see what's already there. So we know that people are engaged in different ways. They like to engage in different ways. So I think you're absolutely right. I think the work that Ali and colleagues have started, and I think as David made the point, it's only the beginning. We don't go, well, that's it, we've done engagement now, we'll sign off the business case and move on. We absolutely need to look at both the formal and the informal ways of engaging the people that we serve and our staff. You know, we can never do enough.
Julie.
Hello, Julie Parker, Non-Exec Director at Colchester. I think the business case is a solid one and articulates the vision very, very well. What I'd be interested in is perhaps I'm not sure who would answer this, but how are we going to ensure that Nick, you spoke about the two organisations being in a good place in terms of their performance and their quality. Ipswich and Colchester has improved. How are we going to ensure that the very busy business as usual that we do over the months, which we know both organisations are very busy. How are we going to ensure that business as usual continues on the improvement trajectories that we've had whilst we go through the transition?
Thanks. Neil, will you pick that up, please?
So I think that's a really important question. I mean, if you look at the business case, it articulates a number of benefits, things that are going to improve within for our patients, both in Ipswich and in Colchester and the surrounding areas. We're going to be ensuring that our management team and our clinicians are going to be working very closely together through strengthening our governance arrangements, making sure that we're absolutely sighted on both of those elements, not only delivering the benefits of the the two organisations coming together, but also what we've regarded as business as usual. So we don't want, as the two organisations come together, to take our eye off the ball and lose that. And so the strengthening of the governance arrangements are going to take both of those things together. It's going to be looking at the delivery of the additional things that we're looking to do and improve on. Nick has talked quite a lot about the improvements in time and the benefits through, for example, logistics is talked about in the business case. That's going to be something that's new in the organisation, and we're going to strengthen our approach to meeting those requirements for patients, but not losing sight of those things that we've become very used to. And as Nick talked about earlier, you know, the two organisations have delivered very good services, emergency services for our patients in both A&E departments being the best in the region. And we want to sustain that, and so continually working not only with the two organisations coming together and learning from each other, but also working with our local partners to sustain that really good performance.
Hand further down, but I couldn't see. It's beyond you, Andrew, and I'll come back to you. Is that Lawrence? It's okay.
Thank you, Chair.
Sorry, I should have said that was Neil Maloney, the Managing Director on both hospitals.
Thank you, Chair. I think it's really important to learn from some of the comments that we've heard this afternoon. Just briefly on the one in relation to engagement, I was quite amazed to be told that we didn't have copies of the FBC available in libraries and other points where people may obtain documents. I think we need to take that on board really seriously, and I suggest we get copies in as soon as we possibly can, and going forward as well on progress. I think that's so important. What I really wanted to focus on was I think the lady's gone, the lady who talked about the FBC looking weak on putting patients first. One of my main criticisms when we were at the outline business case stage was that we weren't seeing the patient benefits clearly enough, and that was taken on board, and the team has worked really hard. And in particular, Crawford and Claire have worked incredibly hard with their colleagues to begin the process of understanding how, from a clinical viewpoint, we can make our services work better for patients. And at the strategic level, we focus very much on making time matters as a central tenet of the new organisation. So I sit here today feeling much more confident that we've got it right. And if the FBC doesn't illustrate that well enough for that lady, then I'm sorry, but I think that it does. But I can see that there perhaps is not enough examples to ensure everybody feels as positive as I do about this merger. So I think in terms of engagement, we need to make sure we focus on getting those examples explained to people more, so that it relates more to individual lives than we have perhaps done. So I think that's something that we can do which would be useful for both populations in Essex and Suffolk. And finally, I just wanted to mention that living and working in Ipswich and being an Ipswich board member, sorry, I'm Lawrence Collins and I'm a non-exec director on the board at Ipswich, has been a huge privilege. But what I see most is how strong the association between the hospital and the community is, something that none of us would want to be lost. And actually, I believe, working in this new organisation, we'll be able to actually strengthen the focus on the local community, not lose it. Whether we can repatriate services or not is a challenge, but we will have the critical mass to be able to argue strongly for that. And there is also the issue about retaining services and developing them. So I think that the FBC illustrates this well, and I think this merger is the right thing for people in Ipswich, and I'm sure in Colchester too, for the future of our local health service. So thank you.
Thank you, Lawrence. Andrew?
Thank you, Chair. I had a similar comment and question to Lawrence just now about being seen and to live through our business case, our central belief, which is that patients are at the centre of everything that we do. And to my slight surprise, as I was sitting here listening to that lady's comments, I realised I was agreeing with her. And then I sort of found out that I was answering my own question, which is always a happy state of affairs, naturally. And that is this, that actually the fact that we put patients right at the centre of what we do is woven into the very fabric of the document in the business case. And for that reason, I'm actually very supportive of the merger, albeit that perhaps we haven't been quite as explicit as we might have been. But I share and understand the views which have been expressed, but that's not to say that we haven't, over the last, however many years it is, 2 years, as we've been going through this progress, had patients' interests right at the very forefront of our minds.
Thank you. And that was Andrew George, as the non-executive director at Ipswich Hospital. Dawn?
Thank you. Dawn Scrafield, Director of Finance. One of the things that I know that we discuss quite often at the board is the challenge that we have around balancing the available resources and obviously trying to invest and improve the services that we provide. And I think for me, the business case and the financial case for change is really important, because as separate organisations, we often discuss how we're going to deliver our cost improvement arrangements and how that means that that will affect potentially some of the resilience for us to be able to develop some of the services that we provide. In any event, we're going to have to deliver £109 million savings across the next 5 years without merging. So actually the merger will allow us to provide a better resilience of service, and it will also allow us to invest in some of the care that we've described. So for that reason, I'm really supportive of the business case, because it allows us a lot more opportunity to use the resources that we have better for patients.
Any other questions, comments from members of the board? As I say, We've been living with these proposals and overseeing their development for quite some time. Okay. If not, then I'm going to ask Nick if he just wants to sort of give some concluding comments.
Thank you, Chair. I have had those moments at 3 o'clock in the morning, because that's when you have those moments, isn't it, where you say, why on earth are we doing this? You know, we could just continue as we are. We've seen improvement at Colchester, and it's on an upward trajectory. Ipswich has and will remain a good hospital, as Colchester is. And is it worth it? And I've been challenged by my colleagues, both execs and non-execs, with the same question. I've been challenged by many of you in the public with the same question, either on Twitter or various other media. And I do genuinely believe this is the right thing to do for local people. I think that where we are in terms of the pressure that the organisations are under from the ever-increasing demand of local people, of the people that we serve, in terms of retaining services and making Ipswich and Colchester an attractive place to work for staff, in terms of the huge investment of £69 million, which I don't believe, and I know this because I've spoken to the people who made the allocation, we simply would not have got that level of investment in local services had we not had a very, very clear future clearly laid out through our business case. So I think for patients, for staff, for the environment, for the investment, this is the right thing to do. It's not the easy thing to do. The easy thing would have been to do nothing and to muddle along. There's nobody around this table that wants to take the easy view if the harder view delivers better care for you, for your families, and for the people that we serve. So I would commend the full business case to the boards. Thank you.
Thank you very much, Nick, and well summed up. I'm now going to move into a formal process of, first of all, asking the Colchester directors to consider the resolution to approve the full business case, and in doing, just to explain to members of the public, in terms of board composition, the board is comprised of both executives and non-executives, and some of those there are statutory positions, and some of those hold voting rights. In the way that we work at both boards, we seek to get everyone's view. So even if people don't have a formal vote, it's very important for me as chair to ensure that we've got an inclusive approach to board membership. But I think on this important issue, I will need to differentiate between when I ask for the Board of Directors of Colchester to consider the resolution. Initially, I'm looking for a show of hands or not a show of hands from those voting board members, but I will then ask other members of the board who don't have those voting rights if they want to approve this or not by a show of hands. I hope that's clear, and I'll do the same also for Ipswich. So to the Board of Directors of Colchester who have voting rights on the board, and considering the resolution, those in favour of approving the full business case, please show your hands. Those against? Right, those non-voting members of Colchester, can I ask for your support or not on this resolution, again initially by show of hands of those in favour? And those against? Okay, it's carried unanimously for Colchester. Coming now to the Board of Ipswich, the same process. Those full voting members for the Ipswich board, please indicate by show of hands whether you're in favour of the resolution. Those against? None. And last but certainly not least, other members of the board who don't have formal voting rights, can you indicate your approval or otherwise by a show of hands? Okay. Against? The resolution was passed unanimously, and indeed both trust boards passed the resolution unanimously. So we will now submit the full business case early next week through to our regulators, NHS Improvement. Moving on, is there any other business that board members wish to raise? If not, then can I formally close this meeting and thank you all for giving of your time to come and share your views and listen to the discussion. Thank you very much. And we will reflect upon, and I think you've heard that from board members, some of the observations that were made, as we do want to continue a dialogue with the communities that we serve. Thank you very much.